Well, before I start, I just want to congratulate Prakash and the entire organizing committee for putting together another terrific meeting. I think the fellows component of the NYEBS is an essential part. It's a really opportunity for us to sort of contribute to your training, I would hope. And then the meeting tomorrow and Saturday is just going to be outstanding in all facets. So today I'm going to talk a little bit about carotid artery management and future directions in that management. I think if we look, we know historically that, strokes from extracranial carotid disease are embolic in nature and originate from plaque within the carotid artery. So historically, if we do a carotid endarterectomy and remove that plaque, it's successful in preventing subsequent embolization and preventing stroke. And this is borne out in numerous randomized prospective trials. So this is very strong level 1 evidence. It applies to symptomatic patients, as we saw in the NASCET trial, with a 17% absolute risk reduction for stroke in symptomatic carotid stenosis patients. The European endarterectomy trial showed a similar dramatic absolute reduction in stroke risk. The VA symptomatic trial similarly. And we went on to demonstrate this in asymptomatic patients, so ACAS and the VA asymptomatic trials also all had highly statistically significant advantages for endarterectomy. We've seen this with angioplasty and stenting, and we've seen improved results with angioplasty and stenting. If you go back historically to some of the original carotid stent and embolic protection device pivotal trials, the Archer trial, the Sapphire trial, the composite stroke death and myocardial infarction rate was somewhat higher. Again, these were in very high-risk patients. They were considered not candidates for open endarterectomy. But if you look over time, as we sort of proceed from the left to the right on the timeline of these studies, you'll see that the results have really improved dramatically for angioplasty and stenting. This is due to one, we're more experienced operators, so I think the techniques that we use we're much more facile with. But you also see better patient selection. We've identified which patients do well with carotid stenting and which do not as well. Octogenarians, for example, is a group that does poorly. Very challenging arch anatomy, does poorly with angioplasty and stenting, and heavily calcified lesions do poorly with angioplasty and stenting. So we no longer treat those patients with angioplasty and stenting. We use an alternate approach. And finally, the advances in technology. The embolic protection is just frankly better. The stents have gotten better. So these things have, I think, account for the improvements we've seen. We have one NIH-sponsored randomized prospective trial, multi-centered in the United States and Canada. It was the CREST trial. Enrolled over 2,500 patients, just about half of whom were symptomatic. And when we looked at the primary endpoint of the study, the aggregate endpoint of major adverse events, the results between angioplasty and stenting and endarterectomy, as depicted in this table, were equivalent. So no difference in the overall primary endpoint. Both treatment modalities were highly effective. And what we saw was the complication rates seen in both endarterectomy and angioplasty and stenting in this trial were superior to what had been reported previously, both for endarterectomy and angioplasty and stenting. If you look at the composition of the complications of the endpoints, you do see a difference. There was a higher stroke rate for 30-day stroke rate for patients treated with angioplasty and stenting, and a higher myocardial infarction rate for patients treated with endarterectomy. So the components of the aggregate endpoint are slightly different, but overall equivalent endpoints there. The other interesting thing we saw was older patients sort of counterintuitively did better with endarterectomy. So if you look at the hazard ratio, here they're equivalent if it's a ratio 1. To the left of that, it's superior results for angioplasty and stenting. So patients 60 years of age, 50 years of age, did better with angioplasty and stenting. And then if you look to the right, they did better with endarterectomy. So patients 70 or 80 years of age did better with endarterectomy. So counterintuitive to what we would have anticipated, but it's an important selection criteria for these patients. So we see how angioplasty and stenting performs in high-risk surgical patients. Are there some technical aspects that we continue to work on that may further improve our results? Well, one is looking at the type of stent itself that's used. And what you see is the free cell area for open cell stents is quite a bit larger than what you see with a closed cell stent. And if you do OCT or IVUS, you can see plaque actually protruding through the interstices of that open cell stent. So you want to have a tighter weave, a tighter mesh to try to prevent that. And if you compare diffusion-weighted hits on MRI post-procedure, you see more of them with the open cell stents than with the closed cell stents. So again, implying a tighter mesh is going to give you a better result. We've looked at our own data, and if you look at the size of the debris, and it sort of makes sense, if you have an open cell stent, you're going to have larger particles that are embolizing, or I should say larger particles that are trapped in the embolic protection filter as compared to a closed cell stent. So again, all these data are fairly consistent. If you look at some of the innovations that are being tested now, we now have mesh-covered stents. So you have your standard nitinol stent and then a very fine mesh that may be at 500 microns, it may be 300 or even 180 microns in terms of the pore size of the mesh. So again, that should help tack down any of that debris that the larger cell size of the stents we're not tacking down. And we'll see how these devices perform and whether industry actually will market them in the United States. They're currently being marketed in Europe, but again, due to reimbursement questions, may not be the case here. If we look at proximal protection, so instead of using a distal embolic protection filter, we just arrest flow or reverse flow in the internal carotid artery. You can prevent embolization with flow reversal, and then there's no pores. A microporous filter still, if it's 100 microns, it's still going to let 100 micron debris, escape through the filter itself. So with either the MoMA, which is really like cessation of flow, or the previous Gore device where you actually reverse flow, that may offer better protection. Here's a case that we did, terrible ulcerated plaque, very unstable, obviously, and you occlude the external carotid. Here you see that, and you occlude the common carotid, do your angioplasty and stenting, and then aspirate the blood that's there, and with the intention of aspirating any particles that may be present. And if you look at the results in these higher risk groups, you really saw very good results, under a 3% stroke and death rate. So very good results even in high risk patients with proximal protection. We can use transcarotid revascularization as well. That's utilizes flow reversal. We do a little cut down in the neck and access the carotid artery directly, and then establish a circuit to send the blood back through a filter and into the venous circulation. And so you see here you have your direct carotid access, you have a reversal of flow, and then go ahead and angioplasty and stent the lesion, wait 2 minutes, and then come off flow reversal. And that's proven to be highly effective. Also, you see the aggregate stroke, death, and MI rate is 3.7% in their pivotal trial. So again, quite good results utilizing this approach. One final thing I'll touch on is best medical therapy. Our medical therapies have improved in terms of management, particularly of atherosclerosis, but other factors as well, antiplatelet agents, antihypertensive agents. And Ross Naylor has done an analysis of this, and he's looked at sort of the patients treated in the medical arms of these various trials over the years. So if you go from 1984 to 2009, you see the medical arm of these trials is showing much lower event rates for asymptomatic. This doesn't apply to symptomatic patients, but for asymptomatic patients, you're seeing much lower event rates in the control group or the medically treated group. Interestingly, you also are seeing lower event rates in the interventional group, whether it be stenting or endarterectomy. So this best medical therapy looks like it also improves surgical or procedural outcomes. And here's just represented. If you look at the medical arm in the second 5 years of the ACST trial, your event rate was under 1% per year for the medically treated patients. So that's a very low stroke rate for those patients. So this is being investigated with CREST-2, another NIH-sponsored randomized prospective multi-center trial in the United States and Canada. We're looking at two arms for this trial. One is angioplasty and stenting versus medical therapy. And the angioplasty and stenting group also receives best medical therapy. And the second arm is endarterectomy with best medical therapy compared to best medical therapy alone. And so they're continuing. They've passed the 50% mark on enrollment. There'll be a 5-year follow-up for these patients, so we'll be interested to see, how best medical therapy and the current types of intervention are going to compare. Final thing I'll touch on is there is a increasing body of evidence that there's microembolization taking place from these unstable carotid plaques. And while you don't see a frank stroke with a measurable neurologic deficit, you are able to measure a decline in cognitive function. So this is being evaluated. Are carotid stenoses associated with and hits on transcranial Doppler, spontaneous hits on transcranial Doppler associated with decline in function, and does function stabilize or improve after revascularization? The preliminary data suggests that it does, but this is a subject for ongoing study, and it is actually being looked at in the CREST-2 trial as well. So continued advances in technology and techniques have shown us improved periprocedural outcomes. Mesh-covered stents, I think, offer an opportunity to tack down even more of that plaque and further improve our outcomes. Flow reversal affords even greater embolic protection for these patients, and the role of best medical therapy in our asymptomatic patients is currently being evaluated. Thank you very much.